Good afternoon to everybody. In the previous class, we discussed about the antepartum hemorrhage, one of the component of placenta. Now we will discuss about the placenta previa. This is very important factor for the antepartum hemorrhage in pregnancy. Placenta previa. What is a placenta previa? What is the definition of placenta previa? Placenta previa is a condition where the placenta lies lower in the uterus and partially or completely covers the cervix. That means, can anybody tell about what is the normal situation of the placenta in a normal pregnancy? Usually, in a normal pregnancy, the placenta will be situated in the upper part of the uterus, upper segment, otherwise anteriorly or posteriorly. But in some of the situations where the placenta will descend down and situation in the lower uterine segment, sometimes it may partially covers the internal loss or completely cover the internal. In otherwise, placenta previa is a condition where the placenta is situated in the lower uterine segment. What is the incidence of placenta previa? The placenta previa affects around 1 in 200 pregnant women, according to one of the studies of 1993. Usually, it is a very rare condition. We may get cases 1 or 2 per month. What is the pathophysiology of placenta previa? The following theories are postulated. One is a dropping down theory. That means there is a pure decidual reaction. Usually, the fertilized ovum will be implanted. The endometrium is prepared for the implantation of the fertilized ovum on the uterus. Sometimes there is a pure decidual reaction, and sometimes failure of zona pellucida to disappear. So this is called dropping down theory. And another type of postulations are persistence of chorionic activity in the decidia capsularis and defective decidual and the big surface of the placenta. Formation of the decidua also is very important for the implantation of the placenta. For implantation of the zygote, and the big surfaces means suppose there is a twin pregnancy where there is a big placenta, it will be occupying in the upper segment and sometimes descend into the lower uterine segment. Or whenever when the patient is anemic, so to compensate the need of the fetus, the placenta will become hyperplasia, hypertrophy, and it will become a big and descend into the lower uterine segment. And in case of RH incompatibility also, the placenta will be very big and edematous. And it is occupying in the upper segment and also descend into the lower uterine segment. See in the picture you can clearly see the situation of the placenta, and we can see the maternal blood in the intermillar space and chorionic villi, which was spiral endometrial arteries that are removed, and the decidia basalis and chorionic plate also is the amniochorionic membrane. Also, we can see the junction. We can see the amniotic membrane and the chorion and decidia parietalis also. See the cervix also. So usually this is a normally decidual reaction of a normal pregnancy. The whole of the placenta will be in the upper uterine segment only. See, this is the picture of hacking of blastocyst, that is The worm is released from the worm. It will be picked up by the femoral end of the tube. The sperm will enter into the vagina and through the cervix it is ascend down and enter into the uterine cavity, and then the fertilization occur on the tube, and it will be again migrated back and is implanted in the fundal area, either anteriorly post. This is a normal phenomena that occur in a normal pregnancy. After fertilization, the fertilized womb will enter into the uterine cavity through the fallopian tube and implant on the endometrial decidual. See the decidual and chorion equally how it will be. What are the risk factors for the placenta previa? One is increased maternal age. As the pregnancy advances, and also as the pregnancy in a normal woman, as the age advances, there are likely chances of placenta previa and multiparity. This is also one of the factors. The more the number of pregnancies, the more the chances of placenta previa. And prior cesarean delivery is one of the factors nowadays we can come across. The incidence is more in this previous cesarean section deliveries. Whenever there is a surgeries on the uterus, like plastic surgeries, if the surgery was done for a uterine anomalies, the chances of this placenta implanted in the lower segment is very high. And smoking is one of the predisposing factor for the placenta previa. And multiple gestation, in a multiple gestational triplets, the more the number of the nutrition the fetus are needed, there is a in the compensatory, as a compensatory mechanism, the placenta will be very big, and so it will descend into the lower uterine segment. In the succinate lobes, that means usually a big placenta will be there, a small like a small placenta, bit of placenta will be there. It is implanted into the lower uterine segment. This is one of the abnormalities of the placenta, which may lead to which may be implanted in the lower uterine segment and lead to more of bleeding, more of antepartum hemorrhage in pregnancy. There are 4 degrees of abnormalities noticed in case of placenta previa. One is low-lying placenta or type 1 placenta. The placenta is implanted in the lower uterine segment such that the placenta head doesn't reach the internal os, but it is in close proximity to it. So the placenta will be completely situated in the lower segment, but that does not touch the internal os. This is called type 1 placenta previa. And second is type 2 placenta previa, marginal placenta previa. The edge of the placenta is at the margin of the internal os. The placenta will be lying in the lower uterine segment, but the edge of the placenta will be touching the internal os. This is type 2 or marginal placenta previa. Third is type 3 is partial placenta previa. The internal os is partially covered by the placenta. Most of the placenta tissue will be lying in the lower uterine segment, but it will partially cover the placenta. This is a type 3 placenta. And coming to type 4, that is central placenta previa, total placenta previa. The placental tissue will be lying in the lower uterine segment, but it completely covers the internal os. That is called type 4 placenta previa. How to diagnose all these types of placenta? Not by clinically, by only ultrasonography will give the exact type of placenta previa. Why should we know about their types? Because it is helpful for the management. Whenever the patient comes to us, this ultrasonography will give a clear picture of the situation of the placenta previa. According to that, we can plan whether to do a vaginal delivery or go for a abdominal delivery. And for the next future planning of and also future management. Vasa previa. The fetal vessels courses through the membranes and present at the internal os. This is very uncommon associated with the highest rate of fetal death. So there is a fetal vessels which are having abnormal course and it will be situated on the membrane and that part of the membrane which is very close to the internal os which contains the fetal vessels sometimes during the just before delivery or during labor it will rupture and cause more bleeding. So the fetal abnormal course of the fetal vessels near the internal os on the membranes may lead to more bleeding. This is called vasa previa. The term anterior placenta previa and posterior placenta previa are sometimes used after ultrasound examination to further define the exact position of the placenta within the uterine cavity and help for the further management of the course. So coming to the clinical classification of the placenta previa for clinical purpose, the mild major degree of placenta previa. What is mild degree? It is type 1 and type 2 anterior. The major degree means type 3, type 2 posterior, type 3 and type 4. For clinical management purpose, it is a mild degree and major degree. What is dangerous placenta previa? The placenta overlies the sacral promontory. The placenta compress if the vaginal delivery is allowed. Cord compression or cord prolapse. So placenta, if the placenta is situated in the over the sacral promontory, overlies the sacral promontory, the, the placenta will compress if vaginal delivery is allowed. The head will compress the as the AP diameter of the inlet will be reduced, there is a compression causing fetal distress. Cord compression or cord prolapse can occur. This is called dangerous placenta previa. Placental migration, progressive increase in the length of the lower uterine segment. So there is an increase, progressive increase in the length of the lower uterine segment and due to trophism. There is a sometimes the lower uterine segment, the length will be increased automatically. The placental tissue will be situating in the lower uterine segment will start bleeding. Especially the bleeding will start when the woman start go into early labor, or sometimes it can occur even in the third trimester. What are the causes of bleeding? The causes of bleeding is inevitable bleeding. Inevitable bleeding will be definitely can occur, and trauma to the lower uterine segment or trauma to the genital tract. Sometimes they will have a heavy bleeding. Trauma means even simple vaginal examination. Sometimes, if it is a central placenta previa At type 3 placenta, type 4 placenta, they will start bleeding heavily and coital act. Whenever the placenta is situated in the lower segment, we'll ask the patient not to have an intercourse for the last 3 months. On the external versions, without knowing that the placenta previa, if they start doing external cephalic version, there is a possibility of bleeding from the vagina and higher rupture of the membranes. And the membranes rupture because the placenta is lying in the lower part of the uterus. They will start bleeding as the membranes will separate that from the uterine cavity. What is placenta accreta? These are different abnormalities that can occur in placenta previa. There are words called placenta increta, placenta pacreta, placenta accreta. Placenta accreta means abnormal adhesions of the placenta to the myometrial wall with the absence of decidia basalis. Usually, the placenta will be separated naturally in the third stage of labor, but here, because of sometimes there may be adhesions of this placenta it will pierce into the myometrial wall. So the separation of the placenta is not so easy because of the absence of the decidia basalis. That is called placenta accreta. Can you see in the picture? Can you see in the picture? Placenta accreta, it will occupy almost 75 to 78% of the abnormalities. So here, see it will pierce into the myometrial tissue, as given in the figure. Placenta increta. Placenta attaches deep into the uterine wall and penetrates into the uterine muscles, but doesn't penetrate the uterine serosa. Can you see in the picture that increta? Increta means it is extending some more. It will pierce the whole of the uterine wall except the serosa into the uterine muscle, but doesn't pierce the uterine serosa. That is increta. Accretum is just enter into the myometrial tissue. Incretum is it is extended up to the serosal level. That is called placenta increta. It constitutes about 17% of the abnormalities of the placenta previa. And next coming to second, placenta pacreta. The placental villi will penetrate the myometrium and through to the uterine serosa. Sometimes that villi will penetrate beyond the serosa of the uterus also. Whenever that time we'll have a bleeding into the peritoneal cavity. Understood? Pacreta means it will penetrate the beyond the serosal level, or that is called pacreta. It constitutes about 5% of the placental abnormalities, but it is a very rare condition. Now coming to the clinical findings, the most of the bleeding that occur in the antepartum hemorrhage because of the placenta previa is painless. The most characteristic feature is painless hemorrhage in the later part of the pregnancy. Sometimes there is a history of warning hemorrhage, sudden profuse bleeding, and bleeding may not occur until labor starts sometimes. The bleeding can occur after the patient enter into the third trimester, especially in the ninth month, or whenever the labor starts, then the bleeding will start. Or during labor also there is a heavy bleeding if it was not diagnosed properly. And abortions, sometimes the abortions are very common in this placenta previa. coagulation defects are very, very rare because it is so coagulation failures are more common in abruptio placenta because sometimes the estimation of the blood loss may not be correlated with the clinical findings. Here, mostly whatever the blood loss we can estimate and correct it early. So coagulation failures are very, very uncommon in case of placenta previa because of the early diagnosis and treatment. Signs. What are the signs we can expect in this woman? The first thing is patient because of the blood loss. There is a patient's most of the time they are anemic, shock. There is a more of blood loss. The woman will go into shock. The increased pulse and the low blood pressure can be evidence proportionate to blood loss. So whatever the shock occur, it is proportionate blood loss. Here the uterus is very soft, relaxed and non-tender, unlike in abruptio placenta. Where in abruptio placenta it is tender and tense and it is irritable. But here it is very soft, relaxed and non-tender. And malpresentations are very common in this placenta previa because of the low space inside the uterine cavity. Depending on the situation of the placenta, the fetus will occupy intrauterine position. Stall birth sign. That means whenever you press the head into the lower uterine segment, there is a bradycardia. This is called a stall birth sign that can be seen as a in case of placenta previa. Vulval infection, if you do local examination, you can see a fresh red blood that is coming through the vagina. It's unlike an abruptio placenta where the blood is dark and it is dark blood which indicate the previous not a fresh blood. So now coming to the differential diagnosis of placenta previa, how do you know it is a different whether it's a placenta previa? We can come across the some investigations and complication management and prognosis. Differential diagnosis is one of the most important differential diagnosis. Revealed hemorrhage in case of abduction or a mixed type of placenta previa. See, both looks the clinical symptoms and everything is looks like same in case of abruption and placenta previa. Only thing is ultrasound can give you the clear picture of differentiation. Okay. Clinically also we can diagnose. And vasa previa, sometimes when the membranes are near the cervical arch during the labor start, they will rupture and have heavy bleeding. That also can be diagnosed on by ultrasound before the woman goes into labor. Marginal sinuses, rupture, normally located placenta with this succinate lobes close to the internal arch. So placenta will be situated in a normally only, but the abnormal succinate lobe, the small lobe will be situated near the internal arch. That may cause a heavy bleeding. And pathological conditions of the genital tract like CA cervix, carcinoma cervix, cervical erosions, and fibroids and mucoid polyp. These are the that may fibroid sometimes polyp may be they may start bleeding or mucoid polyps whenever there is infection and congestion they will start bleeding and mimics like placenta previa. See the types of external abruption and concealed abruption and mixed we can see relatively in both the conditions. See placenta succinata, a big placenta will be there with attached a small placenta will be there. This is which may occupy the internal os during pregnancy and start bleeding. The investigations with ultrasonography of ultrasound transabdominal, transvaginal. We can reach transabdominal also. Transvaginal is more accurate, and transperineal also we can do the ultrasound and do the do the ultrasonography of the lower uterine segment and also the fetus. Color Doppler flow study for placenta accreta preferred in high risk groups. We can do the color Doppler study in placenta accreta. We can know how much is the penetration, how much is the blood supply to that area. And the MRI also we can clearly indicate the extension of the placenta onto the myometrial and other part of the uterus. MRI we can do for a clear picture to know the type of placenta previa. So what to do next? When do you do the vaginal examination? Usually, vaginal examination should not be done in a case of placenta previa. You should remember it unless placenta previa is ruled out. For clinical confirmation done under general anesthesia in operative setup in a term gestation, actually there is no need to know. So in a double set means the patient should be kept in the theater for either for vaginal delivery when minor degree of vagina previa. Then if they start bleeding, heavy bleeding, then we can go for immediately even abdominal delivery. Contraindicated in a grade 3 and grade 4 when there was a partial, the placenta is covering the partially or fully, we should not do the PV examination. Both conditions, grade 3 and grade 4 contraindicated. If at all you want to do vaginal delivery under double setup, in minor degree of placenta, we can do the just before planning for delivery of the fetus. The complications are antepartum and interpartum and postpartum. The intrapartum complications are patient will usually present with anemia and malpresentations and shock, and the interpartum are hemorrhage. We will have a heavy bleeding, whether vaginal delivery or abdominal delivery. Increased incidence of operative interference will be more in case of placenta previa. In the postpartum, PPH is because of the due to atony and retained placenta and also because of the tears. So these are the complications we can expect in case of placenta previa. And puerperal sepsis also, because most of the patients are anemic, there are more chances of having puerperal infection. And coming to the fetal complications, low birth weight babies will be born, and prematurity will be there because they will go into early labor and they will go into preterm labor and asphyxia, and intrauterine growth. Intrauterine death of the fetus can occur if there is more of heavy bleeding and birth injuries, because most of the time we will go for a surgical operative procedures. Management prophylactically to minimize there is good antenatal care and regular checkups. Ultrasonography scan at 20 weeks diagnose the placenta should be confirmed by repeat scan at 34 weeks of pregnancy. And informing the significance of the warning hemorrhage, color Doppler flow study for placenta accreta in women with the previous, especially in a woman with a previous cesarean section. The complication should be explained to the patient, and consent also should be taken for the delivery of the fetus. So what we have to do, admit in the hospital, clinical assessment, ultrasound, blood grouping, typing, hemoglobin should be done. Expected line of management and active line of management, two types of managements are there. And McAfee's Johnson's regime is hospitalization, strict bed rest, catheterize the bladder till the bleeding stops, routine antenatal care till 37 weeks of pregnancy. And active line of management, it is in What are the indications for active line of management? Only is 37 completed weeks of gestation or more, or whenever there is a continuous bleeding, when the woman in active labor, when the fetus is dead. In these conditions, it will go for active management of labor. And ultrasonography will give you grade 1 and grade 2A. Double setup will do ARM and oxytocin drip, and we can allow for vaginal delivery. If any maternal and fetal distress arises during the process of labor, then we can go for a cesarean section. In grade 2 posterior and grade 3 and grade 4 cesarean is a must. Cesarean section indicated in all cases of placenta previa, depending on the condition, improved perinatal outcome of both and mother and child. And LSCS is the choice in all types. Anterior lobe placenta, we can give even in the transverse incision, cut through the placenta, cut the uterine wall and cut through the placenta, deliver the fetus through the placenta. Severe bleeding, sometimes the placental incision and extension of the incision into the uterine artery. Thus, Watt's technique and vertical incision is preferred, but we never give vertical incision. We always prefer to give a lower uterine segment incision and deliver the fetus by cut through the placenta. See in the figure, we can see how they will give in the first stage, give incision, and the placenta also should be cut and deliver the fetus. So, one word about this placenta previa with Acrita. The control of bleeding is difficult. You can try with methadone, ligation of the bleeders over the placenta bed, or pasting sutures of the placental bed can be done. Beeling sutures can be tried in this, or if not possible, uterine or internal iliac artery ligation also can be done. Lower uterine packing also can be done. Placenta is left out under antibiotic coverage. We can remove the placenta as much as we can and then give a coverage. And if as a final decision, if the bleeding is not controlled well by all these things, by even internal artery ligation, go for the cesarean hysterectomy. That is the last resort that should be adopted. The prognosis is improved the perinatal outcome. Cesarean delivery is the best option for this, and we can follow McAfee's regime also it in a minor degree, and prompt referral from the PHC to the prompt referral of the mother from the PHC to the higher center in time can save both the mother and fetus. Thank you. Shirisha?